my topic is about hope for the future. We start sometimes, small, sometimes crazy ideas. Many of the crazy ideas, which a lot of people thought will never reach to the finish line, and they're the game changer. So I think this is really a small glimpse of that, and I would like to cover and zip through rather quickly and make sure that I present the punchline in the end. So some of my disclosures, which I think we have declared elsewhere as well. The most important thing is that a lot of what we discuss is not, actually everything is not FDA approved. It's experimentative. It's in the, and a lot of failures. Failures is pathway to success, is part of success. So you have to fail X number of times before you are successful. So sometimes presenting failure is a good thing. And it's okay to fail. We should allow ourselves and our team members to fail, because that creates that psychological safe space. So these are the very early days of dialysis. You might have seen these machines in museums or in the pictures, really those rotator drum kind of dialysis machines. So this is the rotating drum artificial kidney. So this is around the Second World War. Because, in the World War, the crush injury and renal failure, that was so common. So one was shipped to London, one to New York, one to Montreal, and the last one to Poland. We have, this desire to do more home dialysis from long time ago, because, there are some fundamentals which do not change. Maybe if you are in last century or the century before or the century before, reducing suffering is a fundamental, right? So back in times, people went to see their physicians to reduce suffering. Likewise, I think improving quality of life is a fundamental too. It's not going to change. So there are certain things change, but there are other things which don't change. Quality care and your humanistic doctor-patient relationship, that's not going to change, whether you are 100 years, 1,000 years ago, or 1,000 years down the road. So 1960s, so people were trying to do this portable dialysis. So we use a lot of dialysate, right? What do we do after that dialysate is, it's a single time use, right? PD, there's maybe a few hours of use, but eventually you just discard that. Hemodialysis, this dialysate just goes through the filter one time, it's out in the drain. So there was the concept of reuse of the same dialysate, so you don't have to waste all this fluid. So how to kind of regenerate, refresh, or replenish that spent dialysate. So the cartridge of some zirconium and some other material was used. How to really, reuse that dialyzer. So that concept was there. There were some experiments done, but then it lost its charm for a few years. I hope that it comes back. So this is the picture of Dr. Wilhelm Kolff. Is that the right way to pronounce, Dr. Miller? No. Wilhelm Kolff. Okay. So he is probably, we owe him a lot. He invented first dialysis. He invented the first artificial kidney, built first artificial heart, and developed really the membrane oxygenator. So you can see the ECMO and all that. So there was this wearable dialysis. He's actually wearing that thing you can see as jacket. This is his picture from Nature Medicine, published in 2002. And this is a 3.5 kilogram machine he used and described as dialysis in Wonderland trips. So patients who wear these machines, they can do some rafting, they can do some hiking, they can go really, look at their bucket list as, things to do. So imagine this was back in 1970s. So the dialysis in Wonderland trips were excellent program to rehab renal patients and show them that despite the kidney problems, they could still enjoy life. So these are actually, this is what he wrote himself. So it's not like, so I just quoted from the article. So what are the challenges? So the challenges how we have portability in dialysis with the PD in the current format, PD, HHT, but it's not as portable as, it should be. So we want it to be more portable. So size, weight, space, infection, clotting, really is this efficacy? Are you getting enough dialysis, long-term access? And some other problems. We did not have sorbents. Sorbents is that thing which is used to reuse the dialysate. So as I mentioned before, you have dialysate, you use one time, you just throw in the drain. Now sorbent is something that will keep reusing the dialysate. It really cleans. So it's really a bunch of chambers. It starts from from bottom up. So there is the used dialysate go up, it get purified. There is urease, there is zirconium, there are activated carbon. So it really cleans different impurities which are added in the dialysate. So once spent dialysate, it gets cleaned first. Then we need to have some sort of a mechanism to replenish the electrolytes which are lost. So with the improving sorbents technology, there was more interest to develop some of these futuristic modalities. So the first set of modalities are really the extension of either your PD or hemodialysis, and there are efforts to implant a bioartificial kidney instead of the natural kidney. You can go with the bioartificial kidney, and there are multiple other advances in 3D printing and now xenotransplantation as well. So these are the first some of the reported in the literature. So these are the PD based devices, although you will find few more in different countries, but I picked because there was more data about this. VVAC, so Vicenza, right? Wearable artificial kidney. You can see on the left-hand side. So there is a handheld computer in the necklace. There's a belt that has those tubes which really regenerates the spent dialysate. So it's a PD machine. And then on the right-hand side, this is more like it was probably a better or improvised model because it has some cartridge system, and I'll explain it in the next few slides. So this is the Vicenza one. So a double lumen PD catheter, which has dialysate outflow and inflow line. There is a miniaturized small rotatory pump, so that will keep that circulation going on and on. So there's a circuit for regeneration of dialysate as well. So there are 4 cartridges in parallel. So really, you start with like regular PD. Okay, so body is doing the peritoneal dialysis. So instead of throwing that dialysate out and do the next exchange, you use the same dialysate and try to clean it and kind of reuse it. So sorbents were used, and it's still experimental. So consider this as an add-on or adjunct. So patients, because there was no ultrafiltration control, there was no way to add some electrolytes, or if patients are developing acidosis. So really this was adjunct to the current PT. So the AWAC, which is automated wearable artificial kidney, so that tried to add a little bit, what was missing in the first design. So it has 2 chambers. One is kind of more like a monthly replaceable, and one is daily replaceable. So the way it has some modules. So it's again PD based device. You have this double lumen catheter. So put 1.5 liter of dialysate, that is the reserve volume. And then 500 of fresh dialysate is recirculated in a tidal manner, so 4 liters per hour. And then there's a battery-powered pump. So you generate the ultrafiltration, and in this machine, they added actually the ultrafiltration module. So you can see that it has a daily replacement assembly, which has the sorbent cartridge, which is doing all its cleaning, so that filter, so we can daily replace that. And that also has the enrichment module. So basically, imagine like a sorbent which is doing its job every day, And then they also added some of the electrolytes. So that is changed every day. And the second is the monthly replaceable, which is the ammonia sensor, and what's happening to monitor the sorbents and fibrin and bacterial filters. So I can imagine, I always try to find some analogies in the car as well. You get your regular oil changed more frequently, but the steering oil or your transmission oil is changed less frequently. So really, what is more used, more spent, you have to change. So those were the two PD devices, still experimental in the experiments phase. The hemo devices, so you can see that this is Dr. Gura himself. He's wearing this wearable artificial kidney. It has two 9-volt batteries. We have improvised how we have nice batteries, we have nice miniature like rotary pumps. So that is actually leading to small filters. So there is 375 ml of dialysate. It's how much is like 375 ml? Like maybe a can of Pepsi or Coca-Cola, right? So blood volume is 65 ml. So it's literally like kind of very small. It's 5 kilogram. So there is a double channel pulsatile counterphase flow. I'll show you the picture of that. So imagine the inside the cartridge, so the pulsatile flow. So I'll show you the pulse. So really to increase the ability to do the diffusion and other exchanges. So the sorbent-based gas permeable plastic. So even that plastic is good, and it does do daily exchanges. And this is a blood, and anticoagulation is needed. So this is the schema. And again, I think in the interest of time, if I can simplify this, so there is the same circuit that you can see the blood comes in, goes through the filter, blood goes out. What happens on the side is like this is the dialysate, which after use goes through these cleaning chambers to get replenished, and then you have some module to do some enrichment, the acid and all that. So this is that double kind of the pulsatile flow. This was the instantaneous blood flow waves inside they added those probes. And you can see that this will actually really enhance the clearance. So instead of using this just a simple pressure, you are doing it a duplicative or multiplicative job. So this was the original trial. So 8 patients from UK, 5 males, 3 females. Their mean age is 51.7 years. So they used this device for 4 to 8 hours. This is actually the picture of the actual patient. This is available in the article as well. I have the reference down. The blood flow was 58.6 mean, and dialysate was like 47. So it did offer plasma, the urea clearance, 22.7 milliliter per minute. So it offered urea clearance, it offered creatinine clearance, and there were no major adverse events noted. And then there was no hemolysis, because that's kind of, again, a concern because you're increasing the pressures inside the filter. So FDA approved the clinical trial for this, the first prototype of. So you can see that this is actually the researcher. This is the cool picture. He's wearing the machine himself. And then trial was done, a prospective interventional study, and really looking at the proof of concept and the initial data. And then, So 7 patients, 24-hour worth of treatment. You can see the blood flow was 42, dialysate flow was 43, and these are the results. You can see it offered nice clearance for urea, 17, creatinine, phosphorus, but as you can see through the beta microglobulin, the clearance was slightly low, but still there. The middle molecules clearance was there too. So what happened? Hemodynamics remained stable during this experiment in this trial. So patient. It was well tolerated, and there was some uremic clearance, but then there were some problems too. One patient, treatment was discontinued due to clotting after 4 hours. The other patient, there was discoloration, so they had to stop. And then I think trial was stopped after 7th subject. Okay, I'm given 3 minutes warning, thank you. Because of the malfunction, so they are going through some redesign. So this leads us to the world of this bioartificial kidney. So those trials have been done in the past as well to look at. The first was the RAD, which is if you take a CRRT filter and in series connect to a filter which has the kidney tubular cells, because you can grow the kidney tubular cells in the lab, and you can actually ask them to go and inside the filter. And patients who were on the RAD showed improved outcomes. Another experiment which I like to present is this bioengineered kidney. So in this experiment, what they did, and this has led to the kind of, this concept of 3D printing. A lot of us know about 3D printing. So what they do, they took the animal kidney, put through some detergent. So and that detergent remove all the cellular material. So you see that kidney is gradually getting from red to more like colorless. So imagine in this room, you have removed all the carpets, the roofs, the everything, right? So then in that experiment, they connected this kidney to the bloodline. They added the endothelial cells from the ureter. They added the urothelial cells to see if those cells grow inside. So imagine this room, you gut out everything, only the outside is available. Then you put a new carpet, new walls, and see if those cells grow. And you know what happened? Not only that cells actually engrafted inside that scaffold, but also that when kidney was transplanted, it turning pink and it made some rudimentary urine. So based on that, there is a lot of work going on to do 3D printing, kidney on the chip, because you can actually have those kidney cells lined up in the series and do some drug testing. So the implantable artificial kidney is probably the most popular one. So this is the kidney project from University of California, San Francisco. So you have bioartificial. So this has actually two chambers. Maybe let me go to the next one. So this has two chambers. So one is like really the silicon, very fine nanofiber technology to use these membranes, which have this very defined, very small pore size. And these chips are really stacked one after each other to offer the filtration. So that is the first chamber. The second chamber is the bioreactor, where you can grow the kidney cells similar to what I showed you in the RAD. And the concept is like this machine, which is the size of a coffee cup, can be surgically implanted like a kidney transplant, can give you life of a few years, works on the just on the blood pressure, so you don't need to use any extra pump or any batteries or any other devices like we use for LVAD. So some of the comparison, you can see that the PD machine was less than 2 kilo, the hemo was 5 kilo, the implantable is less than 500 grams. So two of them needs battery, the implantable does not. And again, I think this is going through in the trial phase. Some of the animal experiments are done for the implantable kidney. And this is progressing the project. Are we there yet? Not yet. Will we get there? Hopefully. But patients need more than just a device. They need a comprehensive solution. They need more artificial intelligence, some biosensors that send like a biofeedback, and then the devices to make adjustment based on the volume status, the blood pressure, etc. So we need a smart kidney, not just one device. Last couple of slides. What is the xenotransplantation? So really, when you go cross the barrier from one species to the other. So the initial experiments were primates to humans were kind of stops because of there is a concern of there is a retrovirus which can get activated if the virus is in the new body across the species, but closely kind of primates and humans. So more recently, the genetically altered pig, they took some pigs and did 10 mutations to remove the risk of that viral infection mainly and make it immunely, tolerant. And this is the result of those two transplants. There's another group, they have published their results as well. So you can see that on the left-hand side, how the surgery is done. So the recipient, the top left is the recipient after perfusion, And keep looking at the color of the kidney, because if the kidney is dying, it should turn darker and black, but it did not. It remained pink. And on the right-hand side, you can see that the kidney made urine, and the GFR was also, increased as the time goes by. So this was really to do the proof of concept that, is this safe? Can we do it? So they took, I think, some genetic modification. These patients were brain dead people, so families, everybody, consented. Bilateral native nephrectomies were done. And then, the urine was produced, the creatinine was measured as well. So they looked at the histological patterns to see if there was some response. The new cross-match technique was developed. So what they've proven so far is there were no life-threatening intraoperative complications. There was no pig antigens detected in the recipient blood, which was one of the big concern. And I think this is the very beginning stage of going to the next level, that can this become the next thing? So why do we need all this? I looked at the wait list as of yesterday. We still have, how many patients are on dialysis in the country right now? 600,000, 700,000, that figure keeps changing. I know Chris is here. Chris, do you know how many patients? Okay, so more than 500,000. Out of that, 105,761, they need an organ, and closely more than 91,000 need a kidney. So every day, 12 patients die waiting for an organ. So we need to solve this puzzle of shortage of organs. So I think all of these next generation approaches to address the end-stage kidney disease, this is I think one of the last slides is just showing that which direction the research is going. One is either you develop an artificial kidney, whether this is PD based, whether you wear it, or this is implantable bioartificial kidney, or you generate new nephrons, whether this is 3D printing kidney on the chip, or you do something with their, the immunity. So the need for immunosuppression is lower, and then you cross some of those immune barriers which have not been crossed, or you keep working on the xenotransplantation and try to solve the puzzle of organ shortage in the country. And I really want to thank you for listening, and I hope that time-wise we are above time. So special thanks. I'm very grateful for everybody here, whether we have speakers, the board members, the committee members, and all of us in the room. So when we leave, please remember that. Do you remember the challenge the one ask which I have for the day? So the challenge was that 3 facts which you will remember, take home, help your patient to reduce their suffering. That was the challenge. So please, when you fill out your survey, type what you learned and what you really liked. So thank you.